Hi, my name is Jim Joye. I'm an interventional cardiologist here at El Camino Hospital and a founding board member of VIVA. And today I'm going to talk to you about ultrasound guided micropuncture access and just kind of walk you through how I do it. Don't claim to do it as well as everybody or better than most, but I want to share with you my technique in hopes that it might be something you want to bring into your practice. What we have found over the course of time is that converting from what I now look at as a fairly prehistoric approach to vascular access with just simply palpation and fluoroscopy and using a big needle, the ability to see that artery and to scan it to avoid danger, avoid calcification and plaque, safely get in and out with a micro technique has greatly improved our outcomes, reduced our vascular access complications. Had numerous people come through our lab and have exposed a lot of folks to this and have yet to find somebody who has not found the benefits having dedicated to that type of an approach. So with that said, I'm just going to kind of lay out the playing field here, show you what we use, and then walk you through the sequences of how we go about it. So if you turn your attention to the table, I kind of like to get everything laid out that I'm going to use. I've got a handheld ultrasound probe that's already been loaded and ready. We've got some sterile ultrasound transmission gel. Got some lidocaine for the skin, of course. I have a micropuncture needle, which I like to load with a slip tip, so I've got a little fluid on there. Mandrel wire for the micropuncture, its dilator, conversion to a larger wire so that we can place our sheath, and then as necessary, a scalpel for the skin. So all this is just readily available to us. With that being said, we'll kind of get started here. Just apply a little gel to the outer skin. And then with my left hand, I'm going to do some imaging here. Every patient's a little different in terms of what kind of images you're going to see, some better than others. And one of the things that I'm going to ask right now is that we adjust the gain on the device. So I'm really not seeing at depth quite as well. The bottom left knob, there we go, rotate clockwise. Keep going. It's not a very sensitive thing, a little bit more. That's plenty. All right, so you can see I've got the image backwards. I can tell by the fact that the vein was lateral instead of medial. So you can see this particular image is not as great as some. As I do my scanning here, I've got the femoral artery in the middle. You can see probably a branch there. That's probably the lateral circumflex going off to the 9 o'clock side of the screen. I'm scanning more distally, and you can see now that we've bifurcated. So we're at the level of the SFA and the profunda, and that's always an image that you want to appreciate, because then you know when the distal extent of the common femoral artery has been identified. I'm going to scan north from there now, and what I want to find is a segment of the common femoral artery safely in its midsection that appears to be healthy, at least as healthy as possible, and will be receptive to placing this micropuncture needle. I can see it really well here. It happens to be right at that lateral circumflex, so I'll scan just north of there so I don't have to worry about my wire going into that side branch. I know all of you at some point in time with the non-ultrasound approach to this have had wires go out that vessel. Inferior epigastric is another common path for these wires to go on a detour, and they can have consequences, and so the ability to see these things is meaningful. So with that, I'm just centering the artery right in the middle of the screen, and I'll just do a small skin wheel. It's a little pinch here, dear. I don't want to do a deep injection, because if I do, then that fluid will distort my ultrasound image. I will do a deeper injection one before I put the sheath in. Again, just inserting this micropuncture needle through the skin wheel, and then I'm going to scan simultaneous with advancing this needle. Trying really carefully to bisect the common femoral artery, and I'm applying a little back tension on the plunger, this syringe, so that when I get in front wall, I feel it right away. Now, if you don't get in at first, then you may have to take a little look around, make sure your needle's going where you want it. So side to side. Sometimes I'll bounce the needle just so I can create some distortion in the image, see better where it is that my needle is actually located. And her ultrasound planes are not fantastic. So we're in the vessel. I think we're in the vein, to be honest with you. They're so tangentially located. I'm pretty much, you can tell by the, want to clear that for me? By the lack of flow, that is the case. And so whether it's an arterial stick or a venous stick that you did not intend, the other nice thing about this technique is you've just got a micro hole in it, so it doesn't require any prolonged compression or anything of that nature. Go right back to our ultrasound image and try to redirect this better. I'm right back to that branch point, and you can see my needle did go a little bit laterally there. Sometimes you'll find with these calcified arteries or these hardened arteries that the needle will actually bounce off of. And so I've just used that ultrasound image now, guided my needle a little bit more laterally, and we're nicely and safely into the artery. Take care to advance these mandrel wires. Sometimes they will get hung up, and if they do, you may want to take a look with fluoro. I'll just make sure that we've got good backflow again. Have another round, please. We'll clear that again. I'll need a new mandrel wire. So it doesn't do us much good to show you a nice easy one here. Actually, it'll make me work a little bit. This is a groin that's had multiple interventions, all the more reason to have a good look at what we're sticking into. And it is right at that, I had a little hang up in my wire, and that may have been that branch point. And I can feel my needle bouncing right off that artery. If I scan north and south, if you look at that image, you can see that if I get just to the right of center, it wants to deflect, and then it goes right to the femoral vein. So there we're in the artery again. And we'll just carefully advance this mandrel wire. There we go. For the first time, I think that wire did go up the side branch, up that lateral circumflex. At this point, I like to get a lot of the gel cleared out of the way, just so my hands are not sliding all over the place. And I will give her a more generous injection of lidocaine. A little deeper, dear. I don't generally make a nick in the skin unless it's necessary, just for hemostasis reasons. Switch to 038 or 035, whichever your kit comes with. I'm getting a little resistance there. Probably some tortuosity. I just backed up the introducer a bit. And now we've got our sheath in place as safely as possible. I'll flush that real quick and we'll be ready to get on with our procedure. So what I hope to have shown you in that little vignette is a not necessarily straightforward access. You can see with ultrasound, even being able to see it, there was some little troubleshooting that we had to deal with. One can only imagine in a series of, say, 100 patients like this who've had instrumentation in their groin before, have some degree of calcification, peripheral arterial disease, that if you just go with a palpate and stick type of an approach, you're going to have many more complications in the groin than you would otherwise. So ultrasound guided micropuncture, and strongly encourage that you adopt this approach to minimize your groin complications.